reminder email to anyone we're
Yeah.
missing. We're expecting around 33, I think now, because I had two cancellations this morning.
Cool.
Perfect. Morning, everyone. It's good to have you with us. Just letting a few more people into the room. This is actually the first workshop of the new program at the London Academy, so I'm excited to kick things off. Literally only been off doing workshops for a month, and I simultaneously feel like I've not had the month off, and also that I literally was doing this 2 seconds ago. So it's a bit of a mix, but I'm excited to kick things back off again and to start Paul's series. Which, how many years have you been doing this series now, Paul?
Oh, grief. I think I've been working with HPMA since 2018 in different ways. So this came about, I think, around about 2021, 22. So yeah, about 4 or 5 years doing
Yeah,
this
I think the
series.
whole time I've been working with you, you've been doing this series, so we'll be about 5 years.
Yeah, yeah. So basically, people haven't found me out yet, but this could be the year.
Oh dear. I'm just going to give it another second because I just have one more audio settling. But if you are joining, just double check that your name is recognizable for the register. You can also use your preferred name because we will be working in groups as well today. So make sure that it's something that you're happy to be called by the group. Amazing. Perfect. Fab. So, welcome from HPMA. My name's Izzy, and as usual, I'll be here throughout the session to support with any technical needs you may have. So, if you do have any questions or queries, just drop me a note in the chat box and I'll get back to you as soon as possible. As you can see, the session is being recorded today, but we only share it with those of you who've actually attended. And you will be on mute when you enter the room. That's just to keep the audio clear, but feel free to come off mute, share your thoughts and ideas. These are interactive sessions, so there's going to be plenty of opportunity to work with colleagues today. So do make sure you're in a position to do that. I know it's not always possible or easy when you're in kind of crowded office spaces, but do try your best. And if you are in one of those spaces and you want some advice on how you can minimize the sound behind you, just drop me a note in the chat box because Zoom actually has noise suppression settings now that you can use. So if you want to know about that, just drop me a message and I'll get some more info to you. But I think that is everything from me. Paul, I'll hand over to you.
Brilliant. Well, welcome everybody. My name's Paul Miller, and welcome to Guide to Budgeting. Uh, and Izzy just said that's all from her, but it's not really all from her because what to myself and Izzy do, we kind of drive this workshop this morning. So, as you were aware with Zoom, when you're presenting, I've only got a limited view of the screens in front of me. So if you want this to be as interactive as possible, so raise your hand, that would be great. And what Izzy can do, she can scan all people's hands as well. And so Izzy will point out to me a hand that I've missed. Also, feel free to use the chat functionality as well. Put any comments or questions in that. And again, Izzy will be scanning the chat function from time to time and raise issues. So please, please, please interrupt as much as possible because it's the worst thing in the world for me is just doing a monologue. So we're trying to make it as interactive and as fun as possible. And that's kind of key because the more you put in, the more you get out. And this is basically about a fun session. Now, I know that might sound a bit strange, a guide to budgeting in the NHS, a fun session, but hopefully you'll look back at about quarter to one early on this afternoon and you go, do you know, that was fun. Then again, I'm an accountant, so my definition of fun might not be, not, the normal definition. So, I will not go around the room and get you all to introduce yourselves, but I will do a tiny little bit of introduction on me. I joined the health service in 1983 as a national graduate trainee in Wales. Since then, I've been a director of finance in various organisations for about 16 years, chief executive in various organisations for about 5 years, director of strategy, again, a couple of organizations for about 4 years. Retired full time from working in 2018, did a portfolio career, immediately became a non executive. So I did that for about 6 years in a couple of organizations, including an integrated care board. And then in November 2024, I became a chair of an NHS trust. So I've got extensive experience of NHS finance and boards, and I've been on boards wearing one hat or another continuously since 1994. So that's 32 years of being on NHS boards in both England and Wales and different organisations. So work on the basis I've got a lot of experience, and as well as doing this, I do a whole variety of other things in my portfolio career as well. So, but I mean when I say this is about kind of fun, and the more you get in, the more you get out, and please be as interactive as possible. So, hands up. How many of you have managed a budget before? So how many hands can you see, Izzy? Yeah, Jennifer,
Uh,
I can see a hand come up on my screen.
One at the moment. Let me just flip my screen. If anyone's putting up a physical hand, let me just
I
see.
can see Paul with a physical hand.
We've got a few coming up now. Okay. Four, five, six,
Oh, fantastic.
a
All
few.
right, my job's done. Well, in which case then, it's a wrap. Thank you. I'm going to go out and mow my lawn, which needs to be mowed because I think you guys don't need any help and assistance. But then again, maybe. So this is what we're going to do in the overview of the morning. And just to let you know, you don't have to scribble down furiously. All of these slides I'm using will be coming out on a PowerPoint slide deck, or PDF deck later today. So, uh, just sit back and enjoy. And again, all these slides will be coming out. So we'll be going through introductions. We've just done that. What's a budget we'll be covering. Some bit about budgeting is an end in itself or a means to an end. Importantly, is budgeting an art or a science? Now that's quite a fundamental one, which will a theme I think we'll come back to during the course of the day. A little bit about how the NHS is funded and how that impacts on budgeting, and it does have an impact on budgeting how the NHS is funded. We'll then have a break about 10:30. We'll have a practical example to show how creating and managing budgets is easy. It's not an NHS example, it's a practical example based on roast chicken dinners of all random things. So after that practical example, and that'll be hands-on as well, we'll get into the language of NHS budgeting, then get into some terms around cost improvement programs or difference between cash savings and non-cash savings, productivity improvements, concepts of value and waste, and again, concepts around challenges of budgeting for more effective outcomes. And then the last bit we'll get into the psychology of budgeting, the art of making people bothered, and why I think people professionals have a key role in budgeting and financial sustainability. Mainly because you've got a better understanding, I think, of human beings than accountants. So, and I'll say right up now, I'm a person who thinks, well, actually, budgeting is more of the art than the science. So it's about human beings. So that's what we're going to go through. So, bit of an icebreaker. Izzy, can you put people in groups of about 5 or 6 people for 5 minutes? And can you have a quick chat about this question? What is a budget? And just a bit of a warning. I know that some people are fine going into breakout groups can be difficult depending on your preferences. So if there is, if you are kind of not comfortable going into a breakout group with total strangers, totally understand that. Just feel free to sort of check out and have a little moment and then come back in at the end of the breakout group. So that's just for people that your preferences. So breakout groups for 5 minutes and we'll get back at about 9:43.
Perfect. I'll open the rooms up now.
The NHS is never shy on telling people what to do. I was having a chat with somebody recently about NHS planning, and if I remember the chat properly, is in terms of NHS strategy and planning, uh, there don't tend to be many mysteries. The NHS will tell you what to do. It sets you targets. Also, it'll tell you by when you need to do it. because the targets will have a date. So there's no mysteries there. If you're told what to do and if you're told by when to do it, isn't managing an organization like I'm a chair of an NHS trust easy? I don't need to have a strategy. I just take the strategy off the shelf. I'm being told what to do and when to do it. The problem with the NHS is the centre then doesn't tell you how to do it or who to do it with. So you're left locally to work out how to navigate how to do it. You're left locally to work out who to do it with, which GP, which charity, for example. But there's no misunderstandings about the what you're supposed to do and by when. So the strategic direction is clear and budgeting fits within that framework. So this is an example. It's based on 25, 26. I could have, pulled it off for 26, 27, but they're basically the same. So it hasn't really changed that much. That's why I just basically tweaked the chart, the slide, to say an example. Because the overarching strategic priorities of the NHS are still the three: hospital to community, analog to digital, sickness to prevention. That is what we're all supposed to be doing in our various services and our various hospitals. Everything is around those strategic priorities. The operational priorities are roughly the same. Minor tweak, but they're kind of timeless at this point in time. Reduce the time for people for wait for elective care, improve A&E waiting times and ambulance response times, improve access to general practice, improve access to urgent dental care, improve patient flow for mental health crisis and acute pathways, and improve access for children and young people's mental health services. Those are kind of the six priorities for last year, and they're roughly the same priorities for this year. The reason why they're priorities is every time the government or Department of Health or NHS England go out and ask people, what are you worried about? What are you concerned about? These are the issues they come back with. This is what people are concerned about. They're particularly concerned in mental health, but the impact of mental health on children and young people. And then it's, can I see a doctor? Can I see a dentist? How long do I have to wait for my hip or my knee? And why is it that I wait 11 hours in an ED department? That's what people are interested in. And in a democracy, not surprisingly, that's what we operationally have to move the dial on in the next 12 months. So as night follows day, money and resources will be directed to achieving these goals, these priorities. And then tactical, there's lots of performance indicators to support all of the above. There's a plethora of performance indicators and targets to support all the above. And that's the way the NHS works. So the money fits into that delivery mechanism. This is the bigger picture. So in terms of a bit more granular, and so if you were to read the operating plan for 25, 26, and I would recommend you read the operating plan for 26, 27. It'll be very similar, but the words be slightly tweaked. Um, it just brings out the some measurable targets for when you should be doing this stuff. So for reducing the time that people wait for elective care, it has some measurable targets. So resources will be devoted to achieving these measurable targets. And you can see that for elective, some measurable targets there. You can see that for A&E times. 78% of patients seen within 4 hours is the target. Category ambulance response time should average no more than 30 minutes is the target. By all accounts, as a country, we may well have missed the Category 2 response time by a matter of seconds. They were seconds away when I attended a meeting a couple of weeks ago from actually getting to within 30 minutes, which is quite phenomenal. Because in the past, lots of ambulances have been turned up queuing outside of hospital and weren't able to go out and pick people up who needed to be picked up. So there have been some great improvements. And again, there's targets and resources around improving access to general practice and to dental care. So this is the way the NHS works. It works by taking strategic objectives and priorities, turning them into some operational deliverables, supporting that with some tactical targets and performance indicators. That if we deliver the target and the performance indicator, it therefore must assume we're delivering the operational priority, which therefore assumes we're addressing the strategic priorities. It works like that. So, in a way, money is part of the golden thread of delivering change that people want. Because a lot of these improvements, these tactical improvements, these operational improvements, which help you deliver the strategic change, are only possible if you have money or budgets that are focused and targeted at addressing these things. So, does that make sense so far in terms of what I'm kind of trying to say? Within the NHS, money, the budget that you have that you might be managing is not an end in itself. It's a means to an end, and your organization should be making sure that all of the money is targeted and devoted to achieving the strategic goals that Wes Streeting, the Minister for Health, wants us to achieve. Any queries or questions at this stage? Brill. So that's all pretty straightforward. So, 10 minutes. Is budgeting a human behavioral art or a technical science? If the money is about delivering things that people want, that the politicians want, that the minister wants, that the senior leaders want, that the board for your organization want, is it as simple as getting all your ducks in a row and counting all the cash and making sure you don't spend any more than you meant to? Or is it about something else? So, in your groups, can you have a little chat about this? And we'll get back at 10:08. Yeah, is budgeting a human behavioral art or a technical science? So, groups of six, is he?
Perfect. I will open the rooms up now. Um,
Great, thank you.
okay, they've just got 20 seconds, then everybody will be back. Welcome back if you're just joining us. We're just waiting on everybody else. We've just got 10 seconds or so. Perfect. Welcome back.
Well, welcome back, everybody. So hopefully the question made sense. So, any feedback from the conversations you had in your groups?
I can go, Paul. So we
Thank
had
you.
really good discussions in our group, and I'm sure others will add. But we said there's a bit of both that happens within the budgeting and the financial world. Technical is very much around, this is how much money we have and this is how much we're going to deliver, and then we're already in the middle of the year, we're thinking about forecasts and all of that, and where the money is going to come from. And we're also looking at nationally what's happening. Are there going to be further cuts? Is the government? So yeah, so there's all that technical, there's a lot of that
Yeah.
technical stuff that goes on. But we thought behavioral is a bit more, it doesn't really take into consideration what's happening in the local demographics, what's happening around the presenting problems with the populations that we are serving. It
Yeah.
becomes very biased then, and because of the people who are making those decisions, there's lack of transparency around how those decisions are being made, because the loudest voice gets the money. And even
Yeah.
when you're able to secure some revenue, we don't know then what happens to that money. All we hear is, oh, it's the end of the financial year, that money is gone, and that's it. So yeah, so we think there's a lot more behavioral stuff. Technical bit is there. I don't know if that made sense for.
No, it does.
Yeah.
And what you're explaining there, and by the way, you're spot on the technical stuff. So you're kind of focusing, or you were focusing on the behavioral thing of what service users want, external people. It's the why you've got the money, and things like that,
Yeah.
and the rationale behind the choices, and does it make a difference? Can you close the loop that this money is actually impacting and improving patients and service users and the public's lives?
Yeah, we said there's lack of that evidence and there's lack of that audit process then taking place because decisions come from that very high strategic level,
Yep.
but actually do they fit in with some of the local operational levels? So yeah, yeah,
Uh,
we talked about restructures, Paul. If it,
oh
if
no,
it,
we'll come on to that.
yeah.
So in any other feedback from other groups? Roddy?
I was in a group with uh, um, that mirrored Harjit's uh, thoughts there. So yes, there is a technical aspects very much to accounting, but where you sit as a budget manager, sometimes it can be dictated what your budget is by management accountants that have a slightly sort of warped agenda depending on what's happening. So you can end up with a budget that's a little bit warped in itself. So yes. So and also, I guess there's the human behavior side of it in terms of budget setting. If it's set on outturns from last year,
Yep.
where it be overspent, and then the next year you get more money, and or underspent and you get less money the following year. So there's some of these behavioral and technical traits kind of change the way that you operate and change your objectives.
So we'll definitely get into some of the technical stuff around budget setting. I love the use of the word warped idea from the management
Mm.
accountant. And I can get that. Apologies if I paraphrase this, and Jennifer, I'll bring you in a minute. A warped idea from an accountant could be they basically just set the budget to fit within the money they had left. And if you inherit a budget that you think is insufficient to get the job done, that's a very uncomfortable place to be in because somebody's snipped the golden thread. You think you need £100,000 to get the job done, but you're only given £85,000 to get the job done. And that's a very uncomfortable place to be. And I understand why accountants might be the bearer of that bad news. And as a budget holder, it's a difficult place to be, though, when you haven't got enough to get the job done. Jennifer?
I'm just gonna add to that actually, because I was in a room with others, including Katie and Lucy, and we said it's a both. It's both. And I think Lucy had a really lovely phrase around the art is in the execution. So yes, there's lots of technical ability, lots of technical work that goes in, whether it's variance, modeling, forecasting, but actually the art is in the execution because that includes power, politics, negotiation, um, real life, a bit
Yeah,
of moving around, juggling, and I think the phrase used a bit of a dance.
yeah, yeah. And what that's leading into is the psychology of how you get staff motivated to own the budget,
Mm,
and how you get staff motivated to deliver the improvements or to hit the targets that you want the money to deliver and support.
mm,
Because again, money is not an end in itself, it's a means to an end. And it's that ownership of staff. I've never met a any clinical member of staff in a non-managerial role who comes to work to save money. They come to work to save lives, improve outcomes. You will all come to work to do the best job you can as people professionals. you might, as budget holders or as managers and leaders, realise that somewhere along the line that means you've got to hit this year's cost improvement savings target for the people function. But when you started off in your career, I bet you wanted to help people. So that's where that motivation is key. And that's why I kind of make this point at the beginning before we get into some of the technical stuff. It isn't at the end of the day about the technical, just simply the technical. It's the technical goes hand in hand with the behavioural. It's people owning it. It's and owning it again, not to just any fool, any board made up of fools can hit a financial target if you have no regard for safety, quality, or performance. You can live within the money. But if you have regard for quality, safety, and performance, it then becomes tricky balancing how you hit all of these, achieve all these priorities, and live within the money. And that's the tricky bit. And you have to take people with you. So that's a kind of key sort of takeaway right now is, yeah, this is about budgeting, but it's also about taking people with you on the journey of budgeting. Because if you lose the people, you'll have lost control of the budget, is kind of a general theme. Any other comments before I flick on to the next slide? So this gets into some of the technical stuff now. This is for I don't know which courses you might have done in the past, but this is a bit of a reminder of how the NHS is funded, because it has an impact, a significant impact on how money works in the NHS and how budgeting is constrained in the NHS. So the NHS is funded from Parliament. And it's funded from Parliament, and because it actually is funded in cash from Parliament. Parliament actually votes money annually in a budget and votes money annually for government spending departments. And this is an annual block of cash that has to be spent within the year. And the year goes from 1st of April to 31st of March. Now, we actually do in the NHS things called accruals accounting, debtors, creditors, etc. But at the end of the day, what drives it is this large amount of pocket money. And it's kind of an obscenely large amount of pocket money that we kind of have. Well over 200 billion pounds worth of pocket money we have. So we are trying to shift over 200 billion pounds worth of cash within 12 months. And if we don't spend that cash within that 12-month period by the 31st of March, the cash that we don't spend goes back to the Treasury in simple terms, and therefore we lose it. But also it signals, and Roddy kind of touched on this a bit, if you don't spend the cash in the previous year, there's always a risk they'll take it off you in the next year because you didn't need it, did you? So there's always this thing about spending the cash before the year end, which is a phenomenon you might have heard. We need to spend the cash before the year end. So you spend 11 months of the year saying there's no money, and then somebody finds a large amount of cash behind the back of the sofa, and in March you're trying to spend money, place a training contract, or buy a computer, or resurface the car park, or whatever. It's just the way the NHS has always been since 1948. And because we're funded from Parliament, it's the way we're going to be. It drives the rhythm of financial management. It can come across as a bit bonkers, but it is what it is. So that's the first thing. We are basically funded through cash limits. That cash, and this is an example of 2023, but basically it's the same thing. Just the figures are different because we're now spending over 200 billion, but the same sort of trickle downs happen. The money goes from Parliament, it goes to the Department of Health and Social Care, Some money goes to local authorities, the majority goes to NHS England, some of it goes to some arm's length bodies. The large amount of money that goes to NHS England goes to integrated care boards. It gets trickled down through a formula. And just to let you know, there's another training course that I do, which is basically around how the NHS is funded and financial management to the NHS. Some money goes for specialist things from NHS to specialist commissioning. And then money goes from integrated care boards down to providers through contracts. So there's a clear mechanism of how the money trickles down, and it ends up coming to providers. And say the majority of you work in providers, you receive the money through contracts. And your organisation has a contract with an integrated care board to deliver services. And the services that you deliver are things that help achieve the strategic and operational priorities of the NHS. That's why the operating planning guidance, which comes out every year, is really important. If you want to know what's happening in the NHS in the next 12 months, read the operating plan guidance, because it will tell you what's happening. There's no mysteries. You don't have to be Mystic Meg or look into tea leaves and read what's happening. You don't have to be a psychic. Read the operating plan guidance and it will tell you what's happening in a health system near you, what's happening in your organisation. So some of the recent changes, integrated care boards.
Hi,
Yeah,
sorry, Paul.
yeah, go for it.
I meant to put my hand up and I did a thumbs up by accident. I found my hand up. Can I just ask,
Yeah.
where would we find the operating plan guide?
Yeah, if you Google NHS
Yeah.
operating plan 2026-27, it will come up.
Okay.
And also, if you get onto the NHS England website, it will also come up. But it's a straight Google. If you just Google NHS operating plan 2026-27, it will come up.
Thank you.
Some of the recent changes you'd be aware of, integrated care boards are coming together, but they still exist as basically the buyer of services. They're just getting bigger. They're clustering. And providers still exist. We just might become things like advanced foundation trusts, etc., but we're still providers. So that's why I kind of kept this schematic, because it shows the trickle down. The other thing that you need to be aware of, there's also a thing called the Comprehensive Spending Review. And again, you can Google Comprehensive Spending Review June 2025, and you'll come up with a range of guidance, including the review itself and also various briefings by organisations. But what the Comprehensive Spending Review does, it says, and this is the money the NHS is getting for the next 3 years. So there's no mystery. This is the global budget. And you can see, based on what we have here, NHS England, the resources will go from 195 million last year, increase to 226 million for 28 to 29, which is basically an average real terms growth of 3%, which is not huge. And this is in cash terms. So this includes inflation. This includes pay awards. You can see, because these are the cash limits, this is the big, massive, petty cash limit, or piggy bank the NHS operates out. You can see why the government is being so firm and stubborn on the doctors in residence strike. Because this is the cash they've been voted. And like any budgeting decision, if you spend more money here and you have a finite amount of cash, you have to take the money else from somewhere else to balance the books. And the increases of 3% doesn't sound a lot, but if you were to read the Comprehensive Spending Review, which won't take long because you just look at some of the tables, you'll see the NHS is one of the few government departments that will be growing its budget. Welfare, health, and defence are the big areas of debate. Local government and other ever spending departments are actually shrinking in cash terms, and they'll shrink even more after inflation's applied. Because these are the cash limits that include an assumption on inflation. So again, you can see these are challenging, and within the comprehensive spending review, you'll see reference to savings and efficiencies that people expect. So the government will say, I put more cash in, but if the NHS was more efficient, say 5%, it would have even more cash to spend. So what they then say is they assume a level of efficiency in the NHS, and they tell the public, we'll allow the NHS to keep this level of efficiency, which means they'll have even more cash than the cash we're giving them. But they tell everybody. Sally?
Yeah, sorry. So are you that so you know when the Labour government came in and they suddenly managed to give the doctors the rise that they've been
Yeah.
challenging the Conservative government for? Is that because their budgets had not been set yet? So they basically could decide, oh well, let's give them the rise, and then we'll then factor in after that our budget.
Yes, they in fact they set their own macro budget. It's like a Russian doll. The comprehensive spending review is the master budget of everything. It's the master 3-year budget. Year one is 2026 in this instance. That's hard. Year 2 and 3 will be softer and will be liable to flex. But it's put out there as a planning figure.
Mm.
So what they did when they came into power, they had a manifesto. If you remember, they came in and said, oh, there's a hole in the books.
Yes.
And they came in and they raised taxes, which meant they could spend more.
Okay.
They then said, for example, national insurance went up. So they then basically said, well, we've raised the taxes, we can't do that again, which means they are straitjacketed into, well, minimal tax rises, but have to therefore make cuts in expenditure. They hoped, I guess, that the doctors and residents would have been happy with a one-off deal that was recurring and wouldn't come back again. So, key bit here is the NHS is funded from cash. And it's not a mystery. The cash that we should be having is identified in certain key documents. And this is what the extrapolation of this kind of means. And now this was from April 2026 onwards. So an average of 3% real cash growth after assuming inflation. Large amounts of efficiencies are baked into the NHS. So we're going to have to make cost improvements. There's an expectation of further reduction of waiting lists through extra work. That's extra work with people not being paid for the extra work. They'll just be more efficient. There was real cash built into the planning figures, and that's earmarked for digital transformation, more GPs and more dentists. And therefore keeping NHS pay affordable is key to the above. Because as pay is about 70% of the NHS budget, if you gave everybody a 10% pay rise, but 70% of your budget is pay, that would equate to, if my maths are right, somewhere between a 6 and 7% increase in costs. But if the total uplift is only 3%, how are you going to find the extra increase in cost if everybody had a higher pay award? So these documents set the backcloth for all of the tensions that you see within your organisation. So if you read the comprehensive spending review, that will tell you the medium to long term financial planning scenario and budgeting environment to the NHS. So that would make you realise, okay, there's clearly not a lot of money. There's clearly an expectation of efficiency savings. And if you read the annual planning guidance, it will give you more granular guidance as to what we're trying to achieve, what the golden thread is. So what we'll do after the first break is then come into a practical example of budget setting, which will be a non-NHS example of budget setting. But hopefully I'll try and make sure I can weave it into the NHS approach. It is all about the golden thread. It's all about delivering the big picture. Hajid?
Paul, just a very quick question. You know the slides you showed where the trusts know how much budget or how much the government's giving to each trust. So when our finance people say we don't know what the budget is, that's not true then, is it?
So think of the Russian doll. Think of the Russian doll.
Okay.
Finance people should know from the comprehensive spending review what the current short, medium, and long-term plans to fund the NHS are. The finance team will know from around about Christmas, before the start of the year, what the operating plan guidance is. What the finance team will not know, sometimes not until February or March, is the outcome of the negotiations with the Integrated Care Board or commissioners that they're dealing with. And small percentages make a difference. So if they can negotiate 0.5% more out of the customer, then that will make quite a big difference. If your organisation has a turnover of 500 million, 1% is 5 million. 0.5% is 2.5 million. 2.5 million makes a big difference in your organisation. So negotiations could go down to the wire to get out the extra 0.5%. Also, what your budget holders might not know is if your organisation gets income of 500 million, how that gets allocated to the individual budgets is a matter of negotiation. How much of that gets taken out as cost improvements, how much of that gets rediverted to new priorities is a matter of negotiation. Going back to how your organization's trying to realign the golden thread to deliver the most outputs as possible with the money they've got. But I would say that your organization should, with high levels of confidence, know how much money it's getting to within 95% accuracy right now. Indeed, maybe 96 or even 97% accuracy right now. It won't know 2 or 3%. That's on the margin. And as we are so close to overspending in the NHS, these marginal 2 or 3% make a huge difference. So 2% on a 500 million pound organisation is 10 million quid. So yeah, they might not know the detail, but I bet you they'll know 96 to 97% of the figure. And if you think about, and we'll get into this later this morning, in setting your budgets, you kind of know what the majority of your budget is. So if your team employs 50 staff, nobody's coming in and saying, I'm reducing your team from 50 down to 30. Budget conversations tend to be, well, I want a 51st member of staff. I want an extra member of staff. Or somebody wants to take 2 members of staff off you as a cost improvement. Negotiations are always on the margin. Does that make sense? So the answer is yes, you're right. They should know. But yes, you're wrong. They won't know to 100% accuracy. Which for me, I'm a financial planner. I always think, well, actually, you do know the strategic figure. And you can act accordingly based on all of the guidance ahead. And your organizations will be faced with significant savings plans over the next 3 years. Fact. Your organizations will have to most probably save, I'm guessing, between 10 and 15% of your headcount and budget over the next 3 years. Fact. Nothing's going to change that, particularly not with a war in the Gulf and another economic crisis. So we're going to have a little break. And if we can get back, if that's possible, can we get back at 10:45, if that's okay? So 8 minutes, if we can restart at 10:45. And then we'll get into winner.
Okay, fab. That's us at time. Paul, just so you know, I popped you on mute as well, so you'll have to come back off mute.
Thank you. I'm back. Just checking everybody. Has everybody had a chance to get a cup of coffee, glass of water, and ready to rock and roll for the next block? Yep. Fantastic. Right. We are now going to get into the second area. And let's get my... Right. So there's quite a bit in this next block now, between now and on that next break. So I might end up pushing back our break a little bit, or I might put some of the content the other side to the break. We'll see how it goes. But what I pulled together is a little silly example of setting a budget up. This is particularly for people who haven't been involved in budgeting before, or if you have been involved in budgeting, but sometimes you inherit a budget. This is how you create a budget. Okay. And I've deliberately done it in a non-NHS context, whilst I will then segue into NHS budgets after this, because sometimes it's easier to get the learning if actually you get something which doesn't have all of the jargon associated with it. So this is basically a budget, a little case study about Sunday chicken roast dinners. And you can read it yourself. Two friends decided to do something for charity. They like to cook. They love to cook chicken roast dinners. So they decided to put on a Sunday lunch for 20 homeless people. So that's basically what they did. So in the example on the next slide, they put together a budget. And this is the budget that they created. And this is the budget is created bottom up. It's called a zero-based budget in the jargon, because you start off with a blank sheet of paper. So a key assumptions, there's no income as the dinner is free because it's for charity for homeless people. Things called fixed costs are in blue. So a fixed cost is something that doesn't vary with activity. So whether it was 19 dinners, 18 dinners, 25 dinners, one dinner, 200 dinners, you still need to hire the pots and pans and the cutlery. You still need to hire the kitchen and the hall, including the energy. Fixed costs are things that don't vary with activity. Therefore, variable costs in white are the things that vary with activity. I.e., there's a relationship. The more you do, the more you spend. The less you do, the less you spend. So hopefully this would, if you do any cooking yourself, if you've cooked Sunday dinner, hopefully this is the sort of thing that you'd expect. And that basically is the raw ingredients for creating the budget for this charity lunch for 20 people. And that's what it looks like when you put it into a budget format. Dinner is free, so there's no income. The expenditure, pay costs to zero, as the two friends are giving up their time for free. But then there's the hire of the premises, the equipment, the food costs, the expenditure. So it's costing £242. So the budget's £242. That's their budget. And the average cost per dinner, if they spend exactly in line with the budget, is £12.10p, which is quite expensive. But then again, they've had to hire the premises and the equipment, and it's not just the food. Now, in terms of actual, when they get around to actually delivering on that, if all the things cost exactly the same as they thought they were going to cost, if the potatoes were actually £4, if the cauliflower was £10, if the chickens were £8 each, they would come in within budget because the budget is what they think they're going to spend, and the actual is what they ended up actually spending. And that is how easy it is to create a budget. Uh, so, where's the problem in creating budgets? And this is the budget put into management speak. The strategic, the operational, and the tactical. Now, taking this idea of they enjoyed doing this charity dinner so much, they actually decided to basically leave their jobs as people professionals in the NHS and basically start a restaurant. So the strategy bit was they said they decided to ditch their jobs and start a career in food. That's their strategy. The operational plan is create a 40-seater pop-up restaurant for 6 months and see if it works. Under the catchy title of the best ever Sunday chicken dinner you've ever eaten, that was their kind of business model. That's the gap in the market. And the tactical stuff, the friends would be, the only staff. They would pay themselves. 'Cause obviously, they got rent to pay and mortgages, etc. But to achieve the concept of the best ever chicken dinner that you've ever eaten, they needed to make sure this was a really high quality thing. So this is not the cheapest chicken dinner you've ever eaten. This is the best chicken dinner you've ever eaten. So therefore, they needed to have amazing customer feedback, which meant good quality food at good prices. So that's the kind of the logic of we created a budget based on a charity lunch. They loved it. They've had a change of career, and now we're creating budgets based on this new career. So are you with me so far? So again, what's to go wrong? And just remember now back to what we talked about is budgeted a technical science or an art. This would be really tricky though if you imagine doing this within an NHS organisation. Let's create a new department based on the passion of two people. And let's create and negotiate the budget for this passion for two people. And by the way, there's no new money for this. We're taking the money off other budget holders. So they've got to give us money so we can do our passion. This is all tricky stuff that's based around people then. The negotiations and behaviours of people when they're winning and losing on the money game. But technically, it's not difficult to set budgets. So they're running this pop-up for 6 months. They decided 6 days a week, and they aim to basically sell 200 dinners a day at £10. That's their assumptions. That's their business model. And therefore, what they've simply done is they've just grossed up, based on those volumes, you just gross up the costs. And you work out where you could buy things from. If you buy more, do you get economies of scale by buying at bulk, going into Costco rather than Tesco's, stuff like that. But bear in mind, they needed really good quality chicken as well. So they might have reduced some of the costs down, but they maintained the cost of a chicken at £8. They get free range, top of the class chicken here. So you make a budget based on assumptions. You make assumptions because a budget is a plan. So this is what they think it's going to cost to make and sell 200 dinners a week, 6 days a week. So 200 dinners a day, 6 days a week. And they're working on the price of £10 a dinner. And this is the hope now that it all comes in within budget. They can all create a budget that works. But you can see there's again, fixed costs, there's variable costs in blue. And you can see the importance of assumptions. So if you're creating a budget in the NHS, you have to make assumptions. What is the assumption? How many members of staff do I need to get the job done? How many drugs do I think I need to buy to get the treatments done? It's all about assumptions, and you're testing assumptions. And sometimes you get the assumptions right, sometimes you get the assumptions wrong. These are their assumptions. And this is what those assumptions look like in a budget terms. And based on their assumptions, they think that they could make a profit of £97,000 in 6 months. And the average cost per dinner would be £6.63. And if they're charging £10, that's where the profit comes from. And then what would happen is every month during the 6 months period, they and their trained accountant would basically say, well, are we on track to deliver this? You know, have we sold as many dinners as we thought at £10? Is the income coming in? Is the expenditure going out as planned? Are chickens costing us £8 or £9 now, etc., etc., etc. And they have a budget statement on a monthly basis to identify, are they on track to deliver? So far, so good. Does any queries or questions around this? Because basically, this is creating a budget for a new business venture, rather like setting up a new department in a hospital. Ralph, and then Wendy.
I'm just thinking, would staff not be a variable cost because you're moving from 20 dinners to 200 dinners? Would you not need more staff?
So that's a very good point. There is actually, and I've kept this deliberately simple, there's a thing called semi-variables. You got variable, semi-variable, or semi-fixed, depends you're a glass half full, glass half empty person, and then you're fixed. So staff would be something that there'd be a step change if you got to a certain level of activity. So these guys are assuming that the one person is going to be front of house doing all the serving, and one person's going to be in the kitchen doing all the cooking. And they are assuming that they can somehow produce 200 dinners a day, one person cooking, one person serving. That is their assumption. And on that basis, they think they've got enough pairs of hands to do that. Now, if they got to, say, 300 dinners a day, that might get to a tipping point that they would have to employ either an extra waiter or waitress and an extra cook. So the issue around the assumptions are key. It's that assumption that they can be productive enough to do 200, cook 200 dinners a day.
Okay.
There will be a point in time when clearly they can't do 200 dinners a day. But is that at 215, 255, 295, or 317? That makes sense?
Yeah, it does. Thanks.
Now, that was a really good question because that gets into the whole productivity piece in the NHS. When Wes Streeting says, I want the NHS to be 2% more productive, to do more hips and knees and elective work. So I want you to do more work and I'm not going to give you any more money. Can the operating theatre staff, can the ward staff be more productive and get more work through their ward, their operating theatre, with the same number of staff in post? It's kind of no different for can they cook more dinners with only one cook? There will be a point in time where you're maxing out. But where is that tipping point? And that's again goes to the human part. Your tipping point and my tipping point might be different. It's not a science. The tipping point of a trained, experienced consultant surgeon, they can get through more theatre lists than a junior consultant or a doctor in residence. Fact, because they're more experienced. It's always different. Wendy?
I just wanted to say this is making me really anxious just looking at it. I'm
Oh,
really worried for them.
Oh yeah. Oh yeah. Yeah. We'll come on to that.
Um,
Yeah, it's after you.
I was going to say, have they done any demand work at all? Do they know if there's a demand for any dinners on a Sunday dinners on a Wednesday? I mean,
Oh,
all of these things are just what's the risk
absolutely.
assessment that they've done? All of these things are just, causing me
Yeah.
anxiety, I'm afraid.
No, I'm with you. I'm with you. By the way, at least they recognise over 6 months somebody might get ill, so they put in a contingency for some agency staff in case one of them goes ill or goes on a holiday or something like that. So, but you can see how easy it is to create a budget, and budgets are based on assumptions. And then real life happens. And then sometimes when real life happens, the assumptions fly out the window. So, Wendy, you're spot on. What can go wrong? So, what we'll do is for 5 minutes, Izzy, can you put people in the groups for 5 minutes and we'll come back at 11:05. So, yeah, what can go wrong? And I'll put this slide into the groups.
Yeah, I am thinking about, but I think that's a good call as well. Like looking at the autumn, what can you push for later in the year?
Yeah.
Fab. Welcome back, everyone. I'm just waiting on everybody else. They've got 20 seconds or so. Perfect.
So, hopefully, when you get a kind of a silly little example like a budget for a pop-up restaurant, on something that we hopefully all understand, which is cooking a chicken dinner or a Sunday roast, it makes it easier to get into the issues because budgets are all about the issues. Budgets are all about managing risk. Budgets are all about testing assumptions that work or don't work. So, what reflections and conversations did you have as groups about this winner chicken dinner? Is it going to work? Are they going to remain within financial budget? Are they going to retire as millionaires, selling the franchise? When did
No, we decided if it was a proposition put towards us as Dragon's Den, we would not be investing in this. There's just too many risks and too much that they haven't thought about that was causing concern.
Yeah, and key risk from your perspective, you have to name one.
Oh gosh, so many.
That's okay.
How do you ensure that they're bulk buying of something, for example? If you bought all your potatoes in one go to save costs, they're not going to last the 6 months, they're going to rot. So that's a very simple one that we were thinking about.
Cool. Yeah, yeah. Warehousing, storage. Yeah. Any other comments from other groups?
Well, there's some human factors around. I mean, starters, they asking to raise that many dinners in the week. Are people going to want to come in every day for a chicken dinner, Sunday roast? And do they all come in at the same time? In which case, is there seating? Because there's only 40 seats, right? And also, it's a very different psychological thing to do a chicken dinner for the homeless who are not paying than to be doing something for paying guests who might have different expectations as well. And psychologically, in terms of sense of well-being, that might be very different.
Yeah. Yeah.
It's a basic demand and capacity
Yeah.
piece that they've not done, really.
And what's really clear, and I won't go any further, but in your groups, because you kind of get into it, hopefully, you then can start testing the assumptions, picking it apart, and in effect, the risk, the money just becomes a kind of a financial scorecard for risk in a strange way. Because everything you can assign pounds, shillings, and pence to it, but you can say, well, if this assumption is wrong, that's the financial risk. If this assumption is wrong, that's the financial risk. So imagine if the concept was, oops, skipped over it. Imagine if the concept was moving from a hospital-based dialysis service to a community-based dialysis service. What would be the assumptions? What would be the risks of setting up a new community dialysis service? Or moving from a particular model of looking after children and young people with adolescent mental health issues to a different transformation model of mental health services for young people. It's literally understanding what you're trying to achieve, what the outcomes are, and having a set of assumptions that you may or may not have tried before. So, will these assumptions work? Then linking into those human behavioral issues as well. So, will staff, will service users interface with a community-based mental health service in the same way as they interface with a hospital-based mental health service? Discuss. So again, it's all about assumptions, and it's all about hopefully sitting down and negotiating with people who understand the technical aspects of what you're trying to achieve and constructing a budget that you hope gets the job done, that you hope is part of that golden thread of delivering that plan. So, in this instance, what if they only sold 100 meals a day, not 200 meals a day? And so I just recalculated the volumes on this very simplistic thing of I've just got fixed and variable. And we mentioned earlier, there's a thing called semi-fixed or semi-variable. But if you just varied the variable, because you're buying less, you're selling less dinners, you need to buy less food, for example, they roughly get to kind of break even if they sell 100, all other things being equal. But then you'd have to ask yourself, working 6 days a week, flat out for 6 months and no holidays, and you're paying yourself kind of minimum wage or whatever, is that worth the hassle? Is that worth the stress and the risk and the anxiety? But that's just flexing that budget. And then this is just a summary of the three scenarios. So hopefully that proves that creating a financial budget, it's not scary. You can create a financial budget for anything, going on holiday, setting up a lemonade stall at your summer fete, a chicken dinner, or a community-based dialysis service or diabetic service, or a new hospital, or a different way of moving from a ill health model to a prevention model. But the bigger that you create the project, the bigger you create the teams of people involved in the project, the more complexity you build in because it involves lots of people. Then lots of people have different views. So do you need 6 members of staff or 5 members of staff? Do you need 2 band-aids or 1 band-aid or no band-aids? Do you need a doctor or can you rely on a nurse? Do you need these drugs or that drugs? Every time you involve people in a project, it increases complexity because human beings are human beings. So, but that's a very simple example of constructing a budget kind of from scratch. So, this is an NHS budget report. If you haven't seen one before. And literally, this is the sort of thing that comes out of your financial accounting system. And this is just a quick orientation so you can find your way around here. But in simple terms, it's exactly the same as winner winner chicken dinner. It's got staff and it's got non-staff, pay and non-pay, just as there was pay and non-pay in the expenditure. It's set on a set of assumptions. So going down, there's a classification of the expenditure. There's a cost code, so everything has a code, so it knows its right place in the financial system. There's a description of the type of expenditure it is: senior band 8B, senior band 8C, consultant, etc. Going down. There's a first tranche is always tends to be, or depends how they're structured in your financial system, but there'll be a tranche around the budget. So this is the whole time equivalence around the budget. And the first column is the budget as it's supposed to be. So in this instance, this is the funded whole time equivalence. So you can go down the list, and in total, there should be about 5.1 whole time equivalents in this department. The next column will tend to be the actual, the paid that comes from ESR. And the first thing you'll see is actually there's less people working in this department than they'd budgeted for. So, it starts making you think, how are they getting the job done? And also, when you look at it, the mix of staff is completely different from the intended budget. So there's an intended staffing structure you can see here, but the staff in post tend to be kind of completely different. This is the annual budget. This is the financial cost of the first column. So that was the whole time equivalence of the budget, what was intended. This is the budget of what that was intended. This column here is literally in month, so it's a 1 month slice. And so kind of in simplistic terms, it would usually be a 12th of these amounts. It might vary based on some seasonal adjustments, but the staff budget for 1 month is about 19,000, and that's about 1 month's worth of that. The actual, again, would come from the electronic staff record, and that was what was actually happening, and that should mirror the worked. So the worked whole time equivalent and the cost of that worked whole time equivalent. And then you get the variance. Then the variance is simply the difference between what you hoped you were going to do, the budget, and what you actually did, the actual. And in this instance, there's an underspend of £4,822 £4,882 in 1 month. Not surprising, because there's less pairs of hands working there. If there was an overspending month, you'd have to say that's been interesting. There's less people working, but we're overspending. Would that be a reflection of very highly paid staff or something like that? It would be strange. Then towards the end of this normal budget budget report, you then have the year to date. So I'm guessing by looking at this, we're around about month 9 or 10, because that's about 9 or 10 times the monthly figure. So that's the year to date, that's the actual cost to date, and then the final column is the variance to date. And then underneath it here, you've got the similar sort of logic, but around non-pay. And obviously for non-pay, there's nothing coming out to the electronic staff record. So that's a kind of an orientation of something that you could traditionally see of an NHS budget report. And that's what it kind of looks like, with some little notes which I've just verbally walked through. And you could imagine creating something like this for winner winner chicken dinner. And once you kind of orientate your head around it, if you never had to do one before, it is kind of pretty straightforward. It's the description of the resources, what the budget is. It's what you intend to do. Then you've got the actual, and then the variance is the difference between the actual and what you intended to do, which was the budget. Going back to a comment that was made earlier about kind of accountants being a bit weird, what should happen is the budget should reflect the reality that the manager has in their head of the team that they are employing to get the job done. But quite a lot of budgets are historic and have never been tidied up. So the description in the budget can quite often be completely different from the reality of the staff employed on the ground. And that is not good budgeting practice. It should be tidied up. Because if I was working with this budget, I really would have a difficulty in managing what's going on. I could manage the bottom line and I could say I'm underspending, but my staff mix is completely different to the staff I have in post, which is what I'm being controlled against. Am I being controlled against the budget, which is a senior 8C, an 8A, band 4, and a band 1, and I've missed one member of staff out there? Or am I being controlled against actually what I've got in post? So what should happen, a bit like winner winner chicken dinner, you should have an agreed budget that reflects the work you're doing, that reflects the strategic and operational goals and priorities you're trying to achieve. Now, in finance terms, this is called tidying up the budget, basically. So before going any further, does any of that make sense in terms of what I've described? This is not a good example of a budget report for the reasons of, what your plan is completely different to what's happening on the ground. And if this has been inherited, this mess, it should have been tidied up. What is the plan? Is it the original plan that somebody else signed off years ago, or is it the reality I've got at the moment? So Ralph.
So just say at the end of the year, you see that your paid workforce mix is completely different from your budgeted workforce mix.
Yeah.
For the next year, would you use the actual paid workforce mix as your budget for the next year?
So that's a very, very good point. So if we go on to the next slide, it then goes into your organization's approach to budgeting. So what a lot of organizations do is they do a thing called a historical rollover of last year's budget. So if your organization did that, all that would happen is the mess that existed in the old year would be rolled over into the new year, and you'd end up with this first column that nobody really recognizes anymore. Yeah. So that isn't great. Incremental, you could take basically, you could say, well, it's such a mess. I will tidy up and I'll make some incremental changes which have been agreed. You could do that. Or you could do a zero-based approach, take the approach that they had in Winner Winner Chicken Dinner and say, this is such a mess of a budget. Let's sit down and start again and zero-base it. That would imply a conversation and a negotiation. Now, the accountant might like that, actually, because here you might say, well, actually, you're getting the job done with 3 members of staff. You budgeted 5 members of staff. So what I'll do is I'll happily zero base it based on the staff you got in post. In which case, I'll take as a cost improvement saving the difference. Or you might say, well, actually, please don't take all of it, take half of it, because I want maybe to employ an extra member of staff to do something. But that's an approach. You could zero base it and have a negotiation. Or you could do an activity-based approach. So an activity-based approach is a bit like winner, winner, chicken dinner. It's like, well, how many members of staff do I need for 200 dinners a day? I think 2 members of staff could do it. How many members of staff do I need for 400 dinners a day? And you do it that way. And a combination of activity-based budgeting, based on how many staff do you need to get X, Y, and Z done, supports a zero-based negotiation. But it's not rocket science. If you were being held to account for this budget, you'd say it's a bit of a mess. Please tidy it up. So my actual budget reflects the reality of the people I employ on the ground. And that's where the human behavior stuff kicks in then, because most people hate giving stuff up. So people happy with just that insight into what an NHS budget looks like, in particular what you can see in terms of how it's set and the variances. There are various approaches to budgeting. A lot of it will be based on how financially cash strapped your organization is, or how motivated your finance team is to do a good job. A bad job is historically rolling over budgets without any form of conversation or negotiation. There should be a tidying up exercise every year to make sure the budgets reflect the plan. If you think of that golden thread, if the budgets don't reflect the plan, the budgets aren't actually doing their job properly. They simply just become a bland bottom line cash figure. There are things that impact on a budget that will make it change from year to year. So tariff changes, that's the income you get in hospitals. Every piece of activity has a tariff of a price. Cost improvement programs will be implemented every year because every year your organization has to save money. Every year you're meant to be more productive, so do more work for less staff or the same staff. Every year people move up incremental bounds. Tusif?
Hi, Paul. Sorry, in the box on the left, I didn't understand what does zero-based mean? And
Yeah.
then on the right side where it says incremental drift, what does that mean?
So incremental drift is in Agenda for Change, when you start in a post, you'll be paid, say, at the bottom of the band. And then when you get more experience, you'll move up bands. Now, it's not there are fewer bands than there ever used to be, but you'll still move up bands based on time served. So in budgeting sense, what will happen is your budget will normally be set based on an assumption on where you are in the band. Historically, people might say you'd set them at midpoint in a band. But if your department was full of very experienced staff, if the budget was set at midpoint in the band, but all of your staff had been in post for a long time or at top of band, you'd overspend, wouldn't you?
Yeah.
Because the actual cost of top of band people is more than the cost in the budgeted middle of the band. So some organizations actually budget actually at the point of the person, but that's very time consuming because that means tracking to see if it is at this point of the band. And if you got another job and Wendy came in at the bottom of the band, we'd have to continually flex and adjust the budget. A lot of accountants will say that's too much hassle, too much work, not worth the point. So hence, budgets quite often are set at midpoint of a band. But these are things that will impact on a budget during the year. So people who stay in post longer will cost you more. There might be more demand for more services. There might be new performance targets. And you can read the rest here: inflation, internal developments, and various issues. So budgets.
Sorry, Paul.
Yes.
You did say, but what is CIP again, please?
Cost improvement plan or
Oh,
cost
yeah.
improvement program.
Thanks.
That's the cash efficiencies that you need to save every year. If you
Sorry,
think
Paul.
back to
So when we are looking
yeah,
into people's pay, the budget holders are also looking at the, not just the, NHS pay award, they are also looking at national insurance contributions and pensions. Is this
yes,
also part of the budget allocations?
yes, absolutely. Anything that we as employers have to pay goes into the budget. So the budget will be the full cost of employing people. So that's why technically you need to add up all these bits and bobs and things like this to make sure that the budget is technically created accurately. So that will be the full cost of employing people. So there's various approaches to budgeting. The NHS typically does a historical budget, which unfortunately doesn't always pick up all of these technical things around the impact on the budget. Best practice would be every year the budget is kind of reset from scratch, called zero-based. But the danger of that is you therefore are entering into a renegotiation every year with budget holders, which is very time consuming and it's very challenging. So a lot of organisations actually do what's called incremental budgeting, which is the previous year's budget adjusted incrementally for some of the things on the right-hand side. Adjusted incrementally for a development, adjusted incrementally for cost improvement saving, adjusted incrementally for a cost pressure. So these again are a bit like winner winner chicken dinner. There was pots and pans to buy, chickens and carrots to buy, and gravy to buy, and potatoes to buy. These are the things which are the raw materials of an NHS budget. These are the things that you'll have to make assumptions on when you're setting a budget. So when you get the slides, you just see these are all the technicalities that when you're setting budgets are things you have to form a view on to make sure your budget is set accurately. But in logic terms, this is no different from potatoes, carrots, and gravy. You know, these are the building blocks of a budget. Won't do this practical example, but it's worth thinking about over a cup of coffee. If you're a budget holder, budgets holders have to make decisions within the context of their resources. So if you think of the NHS as like a big cash limit, over 200 billion quid, by the time that money gets down to your organisation, that's maybe 500 million pounds worth of money. By the time that 500 million pounds is broken down and given to your department, like your ward, you might have 2 million pounds to manage your ward. And with that 2 million pounds, you've got a job to do, which is the golden thread. What is the contribution of my ward to the effective running of this hospital? So within a ward manager might have, and you might have this within the people function, your department, you might have questions and queries and challenges. So if a ward manager was short-staffed, coming up to a bank holiday weekend, what would they do? Would they offer overtime, do nothing, call for agency, call for bank, or try and borrow staff from another ward free of charge? And those are the sorts of budgetary questions and challenges that budget holders have. Each one of them will have a cost. Each of those 5 options will have a cost. And those costs will impact on the bottom line financially, but they will also have an impact on safety, performance, and money. And budget holders, what you need to do is make decisions, hit the sweet spot that balance money, safety, and performance. Obviously, doing nothing and running your ward short of staff over a bank holiday weekend is the cheapest option. But will that be safe? And that's what being a manager, being a budget holder is in simple terms. You're always balancing money, safety, or quality and performance. It's a balance. If you're just having to balance money, then life is easy. But if you're accountable for that ward, you're accountable for that clinical area, therefore you're accountable not just for the money, but for the other aspects. And so those are the kind of difficult, we call them budgeting decisions, but actually they're managerial decisions. So, mindful of time, I'll do one more slide, then we'll have a break. We've talked about cost improvement programs. So if you remember, every year the NHS gets a block of money. We have a block of cash, over £200 billion. And every year there's an amount of cash growth added to that, which is real cash. But also every year the government says, but you can be more efficient. So it'll say you can be 2% more cost effective. So in simple terms, it would give the NHS an extra 3% of cash. So on that example of 200 billion, that would be an extra £6 billion. If then the government says you can be 2% more efficient, that would equate to 2% on 200 billion is 4 billion. It would then say, if you were 2% more efficient, you could save £4 billion. And we'll add that £4 billion to the extra 6 billion I've just given you in real cash. And that would mean an extra £10 billion the NHS could spend if it was 2% more efficient. The government would then set its plans based on the fact we had £10 billion available to us. So that makes sense. It's smoke and mirrors. They've assumed you could be more efficient. They've calculated what that efficiency would be. And they've said, and I'll leave the cash with you, as if it was new money. And that drives a thing called cost improvement programs. That's why every year, without fail, your organization has to save money to stand still. Because every year there's an expectation that your organization will save money based on the national assumption of the Department of Health and NHS England. So there are different types of cost improvement program. And in simple terms, there are things called economy. So you are buying things cheaper. So if I could buy rubber gloves in operating theatres cheaper, then I'm still buying rubber gloves for operating theatres. I'm just buying a cheaper product. So if I was running a department with 5 members of staff, but I can run a department with 4 members of staff, then that's cheaper. That's economy. And that saves cash. There's things called efficiency, which is linked to productivity. If I'm more efficient, I've got 5 members of staff in my department. We used to treat 100 patients. If my 5 members of staff could treat 120 patients, I'm more productive, I'm more efficient. And if I work in an organization that gets paid for my work, then doing 120 patients is more than doing 100 patients, and I'll get paid for that work. So therefore, more efficiency, more productivity, if I get paid for the extra work, will bring money in, and that will help us become financially viable. Importantly, though, there is a thing called effectiveness, which the NHS is not particularly good at. Effectiveness is, what if I'm working my socks off, but what I'm doing is not actually producing a good outcome? I'm working my socks off. My team are working their socks off, but actually what we're doing isn't changing and improving people's lives. So effectiveness is basically looking at outcomes and saying, is what we're doing making a difference? Now, personally speaking, the NHS has got a long track record of saving money because of economy, buying things cheaper, reducing skill mix or improving skill mix. The NHS has got a reasonable track record on efficiency and productivity, getting teams to do more work. But the NHS is not particularly good at looking at itself and saying, is what we're doing making a difference to the public and the patient? Because if it isn't making a difference to the public and the patient, then why are we doing it in the first place? And ask yourself and ask your colleagues, sometimes, has anybody read that report? Does anybody read this information? Do these clinical treatments make a difference? And if the answer is no, why are you doing it? And if there's a team of 5 people producing this rubbish, why have we got the team of 5 people producing the rubbish? Go even further than that. Ask the patient, is this treatment helping you? And quite often in mental health, they'll say no. Rather than having a consultant psychiatrist to do something, they'd rather talk to a service user with shared life experience. So again, there's something around saving money, around effectiveness. But that is a schematic that talks about basically different types of saving money. Right, so it is now. It's 11:45. If we come back at 11:50.
That should be everybody making their way back now. Welcome back if you just joined. If you can pop your cameras back on, it just lets us know that you're back with us, or a thumbs up. Thank you, Jennifer. That's helpful. Perfect. Great. I'll come back.
Paul, sorry, can I ask a quick question?
Of course you can.
Does sometimes, like, it sometimes feels when we say that we need to deliver efficiency, does this mean that we have been asked to deliver either same objectives or, demands, or even increased demand, either with the same resources or lesser money?
So, again, a great question. Right. Back in the day, when hospitals got paid lots more money for more activity, the main onus was being more efficient or productive because you could do more work and you got paid for it. Yeah. And that got more cash into your organization, more income into your organization. But within the totality of the NHS, if you're being paid more money because the hospital's doing more work, that means the customer, the commissioner, the integrated care board is having to fund that. And that causes a problem because it could force them into an overspend. So the NHS is cash limited, and if you're robbing Peter to pay Paul, it doesn't help the overall health system that you work in. So in simple terms, what's becoming increasingly important is cash releasing savings, which basically means you're having to save money. You're having to reduce numbers of staff. NHS trusts in the past used to be able to income their way out of problems, earning more money by doing more work. But again, remembering if the more work had to be paid for by the customer, if when the customers run out of money, you got you got no more money yourself. So that's why, as a system, we're trying to save money now, which ultimately means large transformation programs, reduced headcounts. And that's why you'll see a massive challenge on NHS organisations to get their headcount back to 2019 levels, for example. People will produce reports and say, in 2019, your whole time equivalents were X. And now look at you. You got their Y. If only you could get back to where they were, we would save a lot of money. Does that make sense? So just being more efficient and more productive is no longer the great answer because somebody's going to have to pick up the tab for that. So some other things which will be very useful for you, hopefully, when you look at the slides, which won't be able to get massively into necessarily in this workshop. But when we were doing the planning for these workshops with HPMA, it was felt that the concept of value and waste were quite useful to understand. So I'll introduce them quickly, but we won't have the time to get into them in great depth. But getting into building on this idea of outcomes and effectiveness, Are the things that we're doing effective? Are they making a difference to people? There's a concept called value, and we won't get into a group on this, but in the concept of value, this is how you basically assign a number, a figure, or come to a view on is what we're doing helping people, is what we're doing effective in terms of through the eyes of the customer. So value can only be defined by the end customer. In healthcare, that customer is usually the patient. So building on that, things that don't add value are deemed basically, sorry, there are three types of work. There's work that adds value. There's work that you do that doesn't add value. It's actually kind of preparation stuff, but actually it's necessary. So an example of necessary work is if you're vetting a request prior to a radiology examination, or say you're doing a CRB check, a new member of staff is starting and you're doing a criminal records bureau check to see whether they've got a criminal record. It's necessary, but that's not adding value at all to the work that the NHS does. It's essential, but it's not really, treating any extra patients. It's a step you have to do. The focus on being more effective is looking at unnecessary waste. It's steps in a process that actually don't add any value, don't improve outcomes, and things that you could take out. So do those three types of work kind of make sense in terms of when you're looking at a process or a system? There are things that you could say, well, I'll add value. That could be the advice that you give to a member of staff. There are things which are necessary. That could be a CRB check. You have to get to it. In itself, is it improving things? And there are things that actually are just waste, that if you could have your time again, you wouldn't bother doing them. So you could look at any process and categorize it into those three areas. And there are arguably 9 types of waste that you can kind of look for. And I do a course on continuous improvement, and I'll be going into this in greater detail in that course of continuous improvement. But in the 9 types of waste, there's basically moving things unnecessarily. There's holding inventory when you don't need to. There's running around like a headless chicken, that's motion. There's waiting. The NHS is full of waste around waiting. We wait for this. We wait for that. The waiting list is a massive waste in itself. Putting stuff on your filing tray is waste if it's waiting. We over-process like mad. Rather than touch the piece of paper twice, we touch the piece of paper 27 times. Overproduction, we just in case, we overproduce. Defects, we get it wrong and have to redo it. Automation, which is basically, if you automate a poor process, you're just going to have waste. So you have to design a good process and then automate it. This is particularly important as we start utilizing AI technology. Think about your process before you apply the AI. Otherwise, you're just going to get another layer of confusion and waste. And skills utilization. If you've got staff in your department who you're underutilizing, that's a waste. So there are different types of waste. If you're armed with that idea of there's 3 types of work, there's value added work, there's non-value added work, but you need to do it because it's necessary, and then there's the stuff you're trying to weed out, which is waste. You've got the 9 types of waste. You can go through a department or a process and map it. So you map your process of what you currently do. You identify the tasks that you've just kind of put into those 3 boxes, and you try and strip out the stuff you don't need to do. And then you agree what your future state process would be. These are ways of finding cost improvement savings by looking at a process and taking out the stuff that isn't effective, taking out the stuff that doesn't add value. This is an example from a book. You might have heard a concept called lean. And lean is basically the Toyota production system, and it was came out from these authors here. This is the value stream map for producing a can of Coca-Cola. And it's in terms of the paper mill, so that's the carton, it's the bauxite mill for the can itself, it's the corn and the beet fields, which are the key ingredients for a can of Coca-Cola. The reason for identifying that process map, you then can identify what adds value and what doesn't add value. And this is the output of this. They calculated it takes 319 days to produce a can of Coca-Cola from right all the way back to the mine and the field and the forest. 319 days, that's that there. But the actual processing time where value is added, 3 hours. Now, I'm not saying you can produce a can of Coke in 3 hours from the mine, the forest, and the field, but the majority of that 319 days was a waste of time and effort where things were being stored and held, or maybe some necessary things. But the time that things were actually being added value, 3 hours. So if you think it might take 28 days to respond to a query from a budget holder, or respond to a query from somebody who wants advice, might take 28 days. How much of that 28 days was actually adding value to the end user of that people function? Was it 27 days, 23 hours waiting in your in tray? 40 minutes you looking up the guidance, and 20 minutes having the phone call. In which case, the bit where the value was added was the 20 minutes when you were having the phone call giving the advice. But the whole journey took 28 days. So that's the whole concept of looking at value and waste as a lens to try and find cost improvement. So I appreciate that's a very quick run through a concept which I'll be going through more in a workshop on continuous improvement. But it was useful to bring in here as a methodology to find savings in budgeting terms. So any questions before I move on?
I'm sorry, I'm thinking off
Yeah.
the top of my head, so it might be a silly question, but
I
you're
know.
saying it's only like, the 20 minutes you had a call with customer or the patient added a value. But what about the research? If you hadn't done that research, you wouldn't add value to the customer because you don't know what you're talking about, right? So that should be included in added value, surely.
That's according to this methodology, that would come under the heading of necessary waste.
Okay.
You are right. It was necessary because you needed that knowledge.
Okay. Got it.
And the sweet spot is getting rid of the unnecessary waste.
Yeah.
But yeah, but for the person receiving that advice, that thing that made their world a better place, they would place no value on you doing the reading up and the background research, because in this methodology, you is find the end customer. It's the things that improves their life. And you quite rightly, and so I would that's why I use the example of the CRB check is necessary. But but when I'm a new starter, I've never jumped up and down and said fantastic, knowing I've passed my CIB as maybe the happiest person in the world. Just okay, tick a box, move on.
Thank you.
And this is a value stream map for basically a healthcare system around surgery. And it kind of just shows this is the sort of thing that your organizations are most, if they're into total quality management or an improvement methodology or a transformation program that's looking at end-to-end processing, people will be producing these sorts of tables and charts and identifying the steps that they can take out to improve efficiency or improve effectiveness. So we got into now the bit about remembering our early discussion about, is budgeting a human behavioral art or technical science? And yeah, there's lots of technical bits in there. Incremental drift, it's technical. Inflation, it's technical. Activity-based budgeting, it's technical. Zero-based budgeting, it's technical. A variance is technical. But for me, a huge amount of the NHS and budgeting is behavioural. The reason why most organisations do not reset their budget every year is because their director of finance would most probably throw their hands up in horror that meant renegotiating every budget every year with the budget holders. Because if you did that, then most budget holders would say, well, I'm not going to sign off that budget because I don't own it. I don't agree it. I want to sit down with you and have a proper meeting and work out I need an extra 4 members of staff. I need this, I need that. So quite often organisations don't want to get into that zero-based negotiation because it's a difficult human conversation. And quite often they'll just roll over the budget, or quite often they'll just strip out the vacancies. Left justice. You got 2 vacancies at the end of the year, I'll just take them out and let you get on with it. Because it's an easier way of dealing with budget setting because it's based on rules, not conversations. So I'm not saying it's wrong, I'm not saying it's right, but there's a human behavioural aspect to budgeting. And if you think of that example of you're short of a member of staff on a weekend, bank holiday weekend, what do? There's a human behavioural side to that conversation. So there's always human behavioural aspects to budgeting, as well as the technical stuff. And don't think of the technical stuff as an obstacle, because every one of you understood how to set the winner chicken dinner budget. The thing with NHS budgets, they just got some more technical jargon. But if you've never heard of a pea or a carrot, that would be technical jargon. But you've all heard of peas and carrots. But you might not have all heard of, agenda for change increments and stuff like that. It's only jargon. If you pick it up, you learn it and you move on. So budgeting is not complicated. It's just jargon that you just have to pick up, technical jargon. The complicated bit is people. So NHS overspending is more common or has been more common, particularly since COVID and prior to COVID as well. And there is a clear message, though, that is meant to be a thing of the past. So it was commonplace for large amounts of overspends to happen right throughout England, and people just got used to overspending and overspending and overspending, and nothing happened. So the NHS strategy last summer basically said the NHS will restore financial discipline. So there will be no additional funding to cover deficits. So if an organisation overspends, they're going to have to sort it out going forward. Nobody's going to bail them out. And all organisations, providers, need to be in financial balance by 2030. What this means is most NHS organisations will have a renewed emphasis on financial recovery and saving money. And because saving money is going to be a big issue, that's why I did that bit on cost improvements and looking at waste. An example of people saving money in a health economy that I'm part of, There's a new hospital group made up of three foundation trusts. And as of 10 days ago, they had a cost improvement target for this year of £117 million. £117 million they had to save. And they were already halfway through April. So your organisation is likely going to be having to save large amounts of money. And the average cost improvement target in cash terms in the NHS this year is about 4.5 to 5%. So there's a large amount of money to be spent, to be saved in budgets. But the reason why I mention it in terms of it's an art and it's people, there's a very experienced finance director called Simon Worthington. He basically said financial recovery is the art of making people bothered. If your organisation had to save £117 million, how can you get people bothered to save money? Because they don't get paid any more money in their pay packet if they save money. Most people won't get sacked if they don't save money. So how do you get people bothered to save money? So we won't do this. Well, actually, yeah. Can you have a 5 minute breakout group, Izzy, for 5 minutes under this heading here? Where you can read it, and I'll put it into the work groups. How would you get staff bothered to save £20 million in this organisation? So if it can get back at 12:20.
Perfect. I'll open them now. They've just got that 30-second countdown. Just waiting on everybody else. Okay, fab. That's everybody moving back, Paul.
Okay, so how could you get your staff to be bothered to save money, or how could you, as budget holders, be bothered to save money? Any kind of thoughts, reflections, or is this somebody else's problem?
I think I will go if that's okay. So we kind in our group, we kind of thought, I think the first things would be just to talk about it with the staff level rather than saying we have to save, just planting that first question. What, because all of us are doing what we're supposed to do, but we might not seeing it as how we are seeing it today. You know, that value stream, that looks very complicated, but it's a simple thing. So we could ask, we are doing everything, but we need to save some money. What can you do differently? Just that simple question rather than bog down with a lot of information.
Yeah.
That might help, depending on various level of staffing, to think, oh, can you think of something? What do you think? Or we have got one-to-one and appraisal, things like that. Or you can say, what do you think? What we are not doing, we think.
I totally agree. Starting with a conversation.
Have a conversation, like simple conversation.
Sharing the problem. Do you realize? Yeah, no, that's a really great starter for 10. I mean, as opposed to somebody coming in like PwC and saying, here's a massive report, tells you how to save 20 million quid, go off and implement it. When you go like that. So that's a great start for 10. And any other thoughts?
I think so. For me, we were in the same group and we were talking about like how do you trickle that message, say, for example, to a band three support worker on the ward? How do you engage, share the problem, like you're saying, Paul? You should start with language that people can understand, make it simple and put it out there in terms of, well, this is what we are trying to do. It's almost a strategy, isn't it? You're trying to have that sort of strategic thinking, but at the same time having the operational solutions, if that makes any sense. But yeah.
On the next workshop in this series on the 30th of June, it's quality and continuous improvement. And that's where we kind of pick up the concept of value. Because for me, having conversations about is what we do adding value to the patient is actually quite an open conversation. How much of what you do adds value? And I bet you know, if you're cleaning the floors, if you're cleaning the toilet, if you're working on patient transport services, getting people to the hospital, everybody has a view on that was a waste of time. You know, so go back to having conversations with people which are quite open about, is it adding value? Is it adding value to you? Was that training course any good? Did it add any value? Could I have done it online in 20 minutes as opposed to being out of the office for half a day? You know, it's just something about having open conversations. So that's a really, you know, but making sure that everybody, as you said, engage is able to engage, not overly technical jargon. But any other views from the groups and the conversations you've had?
I think building on that, just one thing that came into my mind was around appraisal objectives around this. Because that definitely gets through the whole organization. I'm not saying it's going to be easy or straightforward, but I do think that actually, you know, the way that you've outlined this, there is something about how the burning platform is communicated. We hear this all the time, you've got to save money, but I think we need to change the messaging to engage people to think differently. And one way is through this is an appraisal objective. It's going to look different depending on your level of seniority. And we're all in it together. We've all got a part to play. And I think that might possibly be something to explore.
But that's really powerful because in that golden thread, appraisal objectives are part of the delivery mechanism from going right from the top, the strategic stuff, all the way through to the annual priorities and operating plan, all the way through to tactical issues. If the organization's trying to put a woman on the moon, everything has to be aligned to putting a woman on the moon. And therefore the appraisal and the objectives have to be aligned to that. So if actually, you know, we have objectives around performance and quality, safety and money, then that somehow should be connected in that golden thread. Otherwise, if 70% of our cost is people and people actually don't have skin in the game and don't know what they're supposed to do, you've snapped the golden thread. So that's a really powerful point there. There is a logic. There should be a logic all the way through, like a die test, all the way through to strategy, all the way through to the appraisals and the supervision, and all the way back up again. So this is stuff which, how to get people bothered. This gets into my degree is in political theory. So apologies for a bit of political theory, philosophy stuff. But anyways, power, the ability to control people or things. I'll tell you this, you cannot exert power to get people bothered. You will not be able to exert power to get people to balance the budgets. I'm a chairman, I've been a chief executive. I know I cannot exert power on consultants to do diddly squat. But what I can do is I can influence people. I can influence people to do the things I want them to do. I can encourage, I can create an environment, I can have conversations, I can expose people to information, I can encourage, I can influence. So getting people bothered is based on influence and strategies. People happy with that logic? It's very difficult to put a gun to anybody's head. And that would only work for a short period of time. So financial management, making savings, etc. It's about influencing. Bit of academic theory about influencing, but basically power and influencing, they do overlap. And if you're ever nerdy enough, that's a nice bit of academic theory you can read. You can actually download this book from the internet. It's only short, and you only really need to read chapter 1. But it's a nice little schematic that basically talks about the interaction of power and influence. But what we're doing is we're in the inducement, encouragement, and persuasion box. That's where we are, bottom right-hand corner. We need to make sure that everybody's on the same page. There's no conflict of interest. They want to save money, we want to save money. So how do we get people to align ourselves? No conflict of interest, and we're all wanting to do the same thing. Which kind of brings into, again, this is not a course on influencing, but it links into the human behavior side. Academically, people would say there's 3 generic approaches to influencing people. There's logical appeal. So we need to work together because we need to save £20 million. And there's all these technical bits and bobs here. Some people are turned on by logic. Emotion. We need to work together to save £200 million because there's nothing more important than patients. And a lot of our staff work in the community, and it could be your mother, your grandmother, your child. These are our services. We're custodians of our services. And what we're going to do is we're going to make sure we are as safe as possible. We're going to improve the effectiveness of our services. By doing that, we're going to take out waste. Because nobody wants to be readmitted in the hospital because we got it wrong first time. So if you get it right first time, it'll be a better service, a better outcome, and by the way, we'll save money. So it's emotional. It's about your mother, it's about your grandmother, it's about your kids. And then cooperative, which goes into that great idea about starting a conversation. Starting working with staff about how we could save money around here. Have a project that involves staff. Have a project that involves patients. Have a project that involves clinicians. It's a joint project, co-created, that together we come up with the ideas. And then when we come up with the ideas, because we've co-created it, I don't need to sell it to you because it's your idea. It's my idea. So in terms of those 3 approaches, the one that's least effective academically is logic. Business cases based on logic, spreadsheets based on logic are the least effective. Emotional and cooperative appeals are much more effective than that. The reality is you'll combine all 3, but far too often what we do is we default to logic and management business cases and management reports. But that hardly ever influences the hearts and minds of people. So how to get people bothered if you're ever faced with balancing the budget in your team, how to get people bothered if you're ever faced with saving £200 million in your organization, it's about standing back and thinking, how can you influence people? How you can combine all 3 of these approaches to hit the sweet spot. How you can collaborate is key. Having a rallying cry like safety or getting it right first time or effective patient care is an emotional thing. And recognize logic and numbers have their place, but on their own, they're hardly likely to connect. So does that kind of make sense in terms of at the end of the day, people will ignore the spreadsheet. At the end of the day, people will ignore the management table. So what you've got to do is think about how you can influence people, how you can engage people in financial budgeting and stuff like that. So it is a people business. Most of our costs, 64, my organization's over 70 is on staff. So it is a people business. And if we're trying to save money, then we are going to have to start thinking about how we engage better and more effectively with staff. And yep, we're slightly over. So thank you so much. If you're interested, the next workshop in the series is the 30th of June, and that's continuous improvement in quality. And thank you for a really enjoyable morning.
Thanks so much, everybody. Thanks, Paul.
Oh, just from